Hello, everyone, and welcome. Thank you so much for your patience. Merci beaucoup. An English message will follow shortly. Bonjour à toutes et à tous. Je m'appelle Cedar Sinha. Je suis spécialiste de programme principal au sein de la division Santé mondiale du Centre de recherche pour le développement international, CRDI. Avant de commencer, je voudrais vous informer que la session est enregistrée. Vous pouvez participer à cet événement en français ou en anglais grâce à l'interprétation simultanée. Pour sélectionner la langue de votre choix, veuillez tout simplement cliquer sur le bouton couteau qui se trouve sur la barre de menu en haut de votre écran. Il est également possible d'activer le sous-titrage en direct en haut de votre écran en cliquant More, Language and Speech et puis Show Live Caption. Si vous avez des questions pour nos panélistes, vous pouvez nous écrire via l'onglet Q&A situé sur la barre de menu en haut de votre écran. Et si vous rencontrez des difficultés techniques durant le webinaire, vous pouvez nous écrire un message dans le chat. Hello, everyone. My name is Cedar Sinha. I am a Senior Program Specialist in the Global Health Division at the International Development Research Center, IDRC. Before we start, I would like to share some very important information. Please note that this session is being recorded. You may participate in either English or French, as there is simultaneous interpretation. And to select the language of your choice, please click on the kudo button located at the top of your screen. You may also activate the live caption option by accessing the top menu on the screen, clicking More, Language and Speech, and Show Live Caption. If you would like to ask a question to one of our speakers, please use the Q&A section by clicking on Q&A located at the top of the menu of the interface. If you have technical issues during the webinar, please use the chat. And now, without further ado, I would like to give the floor to my colleague and Director of the Global Health Division at IDRC, Montasser Kamal. Give him the floor to provide some opening remarks.
Thank you very much, Shaitali. Good morning, good afternoon, good evening, everyone joining us from different parts of the world. Thank you very much for being here, and apologies for the technological challenges. Je tiens à souligner que le siège social de CRDI, où nous sommes réunis aujourd'hui, est situé sur le territoire non cédé de la nation Algonquin-Anishinaabe, dont l'intendance de terre et des eaux que nous appelons aujourd'hui Ottawa remonte à des temps immémoriaux. On behalf of Canada's International Development Research Center, I'm pleased to welcome you to the launch of the Cedar Cohort Journal Supplement, titled Context Matters, Real-World Evidence and Impact for Better Sexual and Reproductive Health in West Africa and the Middle East. Le CRDI est une société de l'État canadien dans le cadre des efforts déployés par le Canada en matière d'affaires étrangères et de développement. Le CRDI finance la recherche et l'innovation et collabore avec des partenaires du Sud pour impulser des changements positifs. The core objective for all IDRC programming is to invest in high-quality research and innovation across the Global South to better inform decision and approaches to key development challenges in the global health team. In the development challenges. In the global health team within IDRC, this involves supporting research and evidence translation to reduce health inequalities and strengthen health systems. This supplement and today's event reflect our shared commitment to advancing adolescent sexual and reproductive health and rights, to strengthen inclusive data systems, and to supporting local leadership in shaping policies and programs. Thank you for all the collaboration and all the work that you have done over the years in this cohort of projects, and to the journal editors, and of course to all the work that has been done by the research teams across the various countries. For now, I'm delighted to turn things over to my colleague and one of the supplement's guest editors, Shaitali Sinha, who will frame the context of today's conversation. Thank you and bon webinar.
Thank you so much, Montasser. Merci beaucoup. So now I have the privilege to provide some very brief remarks to frame the journey collectively taken by a group of 16 researchers across 11 countries in West Africa and the Middle East. And as Montasser mentioned, this is the work of the researchers, but for the journal, it was also, I would like to extend a deeper acknowledgement for all the reviewers who are part of the process as well. Now, this journey began at a workshop in Beirut in January of 2018. This is where the name Cedar Cohort took hold. Since that time, members of the Cedar Cohort have worked in their own contexts and across contexts to produce a rich body of implementation research to answer questions of how adolescent sexual and reproductive health services can be more inclusive and effective, how health data systems can reflect everyone's realities, and how change can be co-created and sustained, particularly in fragile and under-resourced settings. Evidence and impact generated from the cohort are rooted in approaches that you'll hear about during this webinar that understand local contexts, champion community mobilization and leadership, and translate knowledge towards achieving positive changes at scale. The work positions the voices, experiences, and co-created solutions from underserved and in many cases excluded populations. It opens spaces for dialogue and exchange and seeding processes for change to address unmet priority needs. Our aim in this webinar is not only to celebrate the journal supplement, but to amplify the insights and expertise from the authors and open a space for dialogue with all of you. We are fortunate to have 8 of the 11 authors from the supplement with us today to provide a brief overview and some key takeaways from their research. We'll begin with the first panel, which will explore how locally grounded approaches can shape interventions that reflect community needs, priorities, and partnerships. As you listen to the panelists, we invite you to post questions in the Q&A section, and if time permitting, we will respond to those questions. Before handing over to the moderator for the first panel, I'd also like to acknowledge the third guest editor for this supplement, which is Anne-Marie Schreier-Roy, who is also joining this webinar. So it is my great pleasure to introduce Marie-Glorieuse Ingabire. Marie-Glorieuse is IDRC's Regional Director for our office in West and Central Africa, as well as one of the guest editors of this supplement. Marie-Glorieuse, over to you.
Merci beaucoup, Shaitali. Est-ce que vous m'entendez? Oui?
Très bien.
OK,
Oui.
excellent. Donc, encore une fois, bienvenue, chers participantes, chers participants et chers panélistes. Encore une fois, désolé pour les problèmes techniques, mais merci encore d'être là. So, starting with this first panel, so we were here, as Shaitali mentioned, 4 projects that embedded themselves in local context and worked closely with communities to ensure that interventions were both relevant and sustainable. So the guiding question for this panel will be how each project engaged with local communities and policymakers to ensure that local priorities, values, and needs really shaped the research, design, and intervention. So we will start with Matt Lowe from the Gambia. So welcome, Matt. You can turn on your camera. So Dr. Matt Lowe is a social scientist, public health population and development practitioner. He's the director of the Society for the Study of Women's Health in the Gambia. So if you allow, in the interest of time, we are going to add the brief bios of our panelists in the chat, so as they're being introduced. So thanks to colleagues for doing that. So Matt, the floor is yours. You have 5 minutes.
Thank you very much, Marie, for the opportunity to briefly talk about our project in the Gambia. Preventing early marriage in rural Gambia, testing and intervention was a 5-year implementation research project that was implemented in the Gambia with the aim of reducing the prevalence of early marriage among girls aged 10 to 19 in 2 districts in the Gambia. At baseline, the aim of the project was to determine the factors that are perpetuating the practice of early marriage, and then to use the information generated to design contextually relevant package of interventions that were implemented in 2 districts in the Gambia, which have the highest prevalence of early marriage in the country. We divided the project into different phases. In phase 1, we wanted to understand the factors that are contributing to the perpetuation of early marriage. And after the information was generated, we analyzed the data to inform the designing and implementation of the package of interventions. The package of interventions that were developed based on the data that was generated included community engagement forum, and also capacity building for key community stakeholders. I have to emphasize that the project at the beginning, at the initial exploratory phase, created community-based committees who were part and parcel of every activity that was implemented as part of the project. So they participated in the collection of the data, in the analysis of the data, but also in the co-creation of the different package of interventions that were implemented in the different communities. And the active participation of community-based committees led to the high acceptance among community members regarding the implementation of the package of intervention. And
Wonderful. Thank you. Thank you so much, Matt, and keeping to the time. So thank you immensely. So now after Matt, we'll welcome and invite Livia Wick to share her insights from the Middle East and North Africa, especially from the countries that comprise the reproductive health working group in the region. So Dr. Livia is an associate professor of anthropology in the Sociology, Anthropology, and Media Studies Department at the American University of Beirut. So also you find her brief bio in the chat. So over to you, Livia. You have also the 5 minutes.
Hello, everyone. Thank you, Marie-Glorieuse. So my name is Livia Wick, and I direct the Reproductive Health Working Group in Arab countries and Turkey. And I'm speaking today on behalf of the coordinating committee of the network, and those are Hanan Abdelrahim, Jocelyn de Jong, William Hamoude, Aisha Jantesh Siolyu, and Yassim Yassin. For the special issue, the 5 colleagues and I wrote a commentary about the question of what is context anyways, and I'm going to talk a bit about that commentary. It's connected to the organizing question of this panel. How did your project engage local communities to ensure that local priorities were part of the research design? So the local communities in this project are a community of researchers in the MENA region working in reproductive health. The Reproductive Health Working Group is a capacity building network that works on supporting researchers who work in institutions in the region. And RHWG has been interested in local priorities in terms of thinking about what context is. And so in this commentary, we thought about context in three ways. First, as an object of study. Second, as a way to structure the network itself. And third, as a way to conceptualize support, research support. So I'm going to talk very briefly about these 3 points and then conclude. So context as an object of study. Researchers in reproductive health are faced with dilemmas when doing research and contextualizing it. So on the one hand, in the MENA region and in many regions of the world, there have been tremendous improvements in demographic and health indices since the beginning of the 20th century. On the other hand, the region continues to be the sites of wars and crises and natural disasters, which are accompanied by suffering and loss of life. So the context in which researchers collect empirical data, in the social sciences you call it the field is one in which health systems are destroyed and people experience loss and instability, and demographic and health indices plummet. And so researchers at RHWG over the years repetitively pose questions about, okay, what have we learned about researching experiences of suffering and of loss? Number two, context structures the network activities. So the question of context seeps into all the network's activities, especially the research workshops. These are workshops that are organized every 2 years, and researchers present work in progress and get feedback from colleagues. And in addition, the workshops are a place for researchers to share challenges of doing research in crisis-prone areas, but also of doing research in institutional cultures that limit the work and careers of women researchers. And this is often taking place in what we call the corridor talk. So workshops are a place for researchers to overcome various kinds of isolation. Isolation due to militarization and wars in the region, and also isolation due to institutional cultures. And the third and final way in which we think about context as a way to conceptualize research support. So recurrently, RHWG members have been displaced by wars and crises. In 2023, Sudanese colleagues were displaced to Cairo. In 2024, Palestinian colleagues from Gaza were displaced to Cairo. A decade ago, we had Syrian colleagues, and also Syrian colleagues displaced by war, and Turkish and one Egyptian colleague fleeing persecution. So RHWG has tried over the years to support these scholars through small research grants and also through having them join the research workshops. Again, the purpose is reducing the isolation of researchers. So in short, to conclude, we have learned over the years that contextualizing research projects is not simply about putting together a historical and social story alongside the work on reproductive health. It's not just a setting for research. We've learned that contextualizing means thinking about what the concept of context does, who it includes, who it excludes. The context itself shapes the kinds of research questions being asked. And we've also learned that to do research, we need to overcome the isolation of the researchers themselves in a militarized and war-torn region. And this has been a central goal of the Reproductive Health Working Group. And thank you for listening. I'm done.
Thank you. Thank you so much, Livia, for that intervention in really highlighting the context, and especially in this very difficult circumstances. So next, we welcome now Irene Eze from Nigeria. So Dr. Irene she's a consultant public health physician and associate professor at the Alex Ekwueme Federal University, Nigeria. So also please find her bio in the chat. So Irene, you have the floor for 5 minutes. Not sure if Irene is connected. If not, while we're waiting for her to connect, sorry.
No, go ahead, Mary
Okay.
Glorious.
Yes, so as we wait for her to connect, so we can move to our next panelist, who's Ama Feni in Ghana. So Professor Ama Pokwa Feni is an associate professor at the Institute of Statistical, Social, and Economic Research at the University of Ghana. So again, also you find her bio in the chat. So Ama, great to see you, and over to you for 5 minutes.
Thank you, and good afternoon or good morning, everyone. I'm pleased to share insights from our CASA project that was an initiative that covered the economics of adolescent sexual and reproductive health interventions in Ghana and Senegal. But today I just want to highlight one aspect of the work we did in Ghana to share some of the foundational information that we got from the process we took with our stakeholders. And this one is the first objective, where we needed to identify the priority interventions with concrete and detailed implementation requirements to achieve improved ASRH in Ghana. We started quite obviously with a very in-depth situational analysis, and then we engaged a multi-stakeholder team here in Ghana, a team that was constituted with stakeholders from the Ministry of Health, from the Ghana Health Service, with our adolescents in beginning. The process meant ranking using the WAHO. WAHO is the West African Health Organization framework that had 4 criteria for selecting these projects. And the criteria was feasibility, acceptability, potential impacts, and also sustainability of the interventions. And if we move to the next slide, I will show you what the process resulted in. And so after doing these stakeholder ranking workshops, after going through this criteria, we came up with the top 4 prioritized interventions. And these were adolescent health hubs, or health clubs, as we call them here in Ghana, looking at interventions that also empowered or focused on sexuality education for girls. We also looked at capacity building for family planning and maternal health services. And finally, we also ranked e-health tools for adolescent outreach, because we recognize as we have gone along this journey that many of our adolescents are quite reluctant to come into our facilities, but can be reached using these e-health tools. And so these were the 4 most top interventions that our stakeholders helped us rank. And this step actually helped us to move on to the next stage, where we had to cost these interventions and also find out what the funding gaps were. And this process has gone on for the past 2 to 3 years. one of the things I need to highlight with this particular project is the fact that it was deeply contextualized, because we took into consideration cultural norms, issues around acceptability, and what our stakeholders hold as our national priority areas, and these align with our policies as well. So it has been a very engaging process, and we've seen the benefits of this, because we recognize that in doing this, we have aligned with what our national plans have been. And I will stop here, and if there are any questions as we go along, I'm happy to engage and provide more information. Thank you.
Thank you. Thank you very much. Let's see now if we're able to have Irene. Is she? And she's connected. If maybe some technical issue, it just moves to the next set of panelists and see if we can have her probably after. So I want to thank all the three panelists, and now back to Cedar for the second panel, and we can come back to Irene after. Hopefully she'll be able to speak.
Thank you very much, Mary Gloriose. Irene, when you can unmute, let us know, and we'll be happy to hear from you. In the meantime, let us move to the second panel of this webinar. And in this panel, we dive into the intersection of gender, power dynamics, and data systems. Each of the projects that you will hear about shows us how research can not only identify exclusion, but actively dismantle it by transforming both norms and systems. Our main question to the four panelists is, how did your project address gender and power relationships across family, community, and systems levels to improve sexual and reproductive health outcomes? So I'm going to begin with Dr. Desmond Klue, who will speak on gender norms and adolescent sexual and reproductive health in Ghana. Dr. Desmond Klue is a senior research fellow at the Institute of Health Research at the University of Health and Allied Sciences, Ghana. And again, you can find his bio pasted in the chat. So Desmond, over to you.
Thank you very much, Natalie. And good afternoon, good morning, good evening to everyone, wherever you are joining us from. So our research was, the main topic was to strengthen capacity of health management teams to use the DIMS data in engaging stakeholders for effective.
I'm just going to interrupt you for 1 minute to ask if you can turn your camera on if possible, but I just wanted to let you know if you can. If not, that's okay. I'm sorry, I apologize for the interruption.
It's okay. So the main reason was to strengthen the capacity of health management teams to use the DIMS data in engaging stakeholders for effective decision making in addressing teenage pregnancy in the Volta region of Ghana. So basically, this project was an implementation research project that the overall goal was to strengthen and increase the ability of the health workers to use what data they have from the health facility to solve adolescent health problems. But more specifically, was to explore the gender difference in adolescent health needs among adolescents in the Adaklu districts. So as part of the baseline data, when we collect the baseline data, we identify a lot of issues that has to do with gender. And one of the issues that we found out was that most of the adolescent boys and girls do not communicate with their parents when it comes to sexual issues. Their communication was very poor. So when we engage them on that result, one of the interventions we proposed together was to train and empower mothers to effectively communicate issues of when it comes to sexual issues with their adolescent children. And why we focus on the mothers was that the adolescents themselves mentioned that they will feel more comfortable communicating with their mothers compared to their fathers. And when we confine from their fathers, they also agree that we should train the mothers to communicate with them, and they will support. Another issue too was that there was an existing health clubs in the district, but the fathers were not so sure what the children, the health workers teach the children during these adolescent health clubs. So they do not allow them, since they are the decision makers, they don't allow them to go for these health clubs meetings. So what we did was that we invited them. They proposed that we invite them, the men, to come and sit in the clubs to hear what they tell them. And when we did that, the result was that they now are confident that, oh, these adolescent health clubs are there to protect their children, to make them take informed decisions. Another thing was to empower the community members on how to address specific adolescent health needs of boys and girls, because we notice the health needs of boys and girls are different, and these community members have different ideas. So what we did was to have a debate and educate them on the specific needs when adolescents are growing, the changes that they go through, how they should understand them, how they should deal with them at the community level. We did that. And the last one was also to build the capacity of health workers, because we realized that adolescents visit to health centers for information and other services were very low, because the adolescents said that sometimes the attitude and the behavior of these health workers, when an adolescent walk and want to know about condoms and contraceptives, the health workers do not really engage them properly. They are not professionals. They judge them morally. So we build the capacity of the health workers on how to become more professional and to address the needs, the specific needs for adolescent boys and girls. So in a nutshell, what we realized was that championing gender issues, gender equity, is very important when we want to achieve a very good reproductive health outcome for adolescents. Thank
you. Thank you so much, Dr. Klug. That's so fascinating and interesting how you were looking at the issue of adolescent sexual and reproductive health and exploring the engagement of adolescent boys, girls, parents, community members, leaders, as well as community health workers. Very interesting. Now we're going to go to Jordan and hear from Dr. Yusuf Cedar. Dr. Cedar is a professor of epidemiology at the Jordan University of Science and Technology. And you can find his bio as well in the chat box. So over to you, Dr. Cedar, to tell us about your project and how it addressed issues of gender and power dynamics.
Thanks, Shitali, and you are welcome to Jordan. Hi, everyone. Our project was about establishing stillbirths and neonatal death surveillance system in Jordan, abbreviated as JSANS. JSANS is an electronic surveillance system implemented in Jordan to monitor and analyze stillbirths and neonatal deaths. It aims to improve maternal and newborn health by generating reliable and timely data that inform policy, planning, and targeted interventions. Next slide, please. JSANS is directly linked to the quality improvement system through a structured death auditing process that enables hospital committees to systematically review each stillbirth and neonatal death, identify avoidable factors, and implement corrective actions at both the facility and health system levels. Through this continuous cycle of surveillance, audit, and action, JSANS serves not only as data collection tool, but also as a catalyst for improving the quality of maternal and neonatal care across Jordan. The JSANS project addressed gender and power dynamics at multiple levels. At the system level, the surveillance database collects detailed socio-demographic data and breaks down mortality by gender, nationality, geography, and socioeconomic status. The system's equity indicators enable tracking of disparities affecting women, particularly those from marginalized communities like refugees and adolescents. The JSANS dashboard reveals hidden inequities and hold the providers accountable to vulnerable groups. This transparency led to real action. Once the disparities became visible, hospitals took steps to improve care. Several success stories have been documented, showing how staff use JSANS data to guide quality improvement efforts. At the facility and community level, the project established death review committees in each hospital, bringing together obstetricians, pediatricians, nurses, and midwives to examine each stillbirth or neonatal death. In these committees meetings, participants explicitly discuss cultural and gender factors such as women's decision-making power and harmful traditional practices as modifiable contributors to deaths. Within families and communities, JSANS reinforces women's voices by requiring patient interviews and complete records. The surveillance forms prompt data from mothers and families about each death, ensuring that social factors like family support, delays in seeking care, delays in reaching care are all recorded. In one study, nurses and doctors reported that having these data gave us power to raise concern with colleagues. For instance, when JSAN's data revealed a high cesarean rate or possibly recurrent stillbirth, providers saw clear evidence of modifiable problems and acted on them. By mandating comprehensive recording of maternal histories, in line with WHO quality standards, the system helped ensure that issues like early marriage or lack of autonomy among girls and women are not omitted from the analysis. In sum, JSANS address gender and power imbalances by putting equity data at the heart of the health system, by institutionalizing inclusive audits, and by elevating women's reproductive rights within a clinical decision making. Thank you so much.
Thank you so much, Yusuf, Dr. Kara. That was very interesting, the way in which you demonstrate the importance of gender and social norms within different systems and different practices and how it influences outcomes. Now we are pleased to hear from Dr. Princess Achampong, and we are going from Jordan to Ghana. So this is our Middle East and West Africa cohort. You're going back and forth from the two regions. We hear from Dr. Princess Achampong, and she is a lecturer at the Kwame Nkrumah University of Science and Technology. And again, you can find her more complete bio in the chat. Dr. Achampong, over to you.
Thank you very much for this opportunity. I had my PhD through this project, and so I'm one of the impact stories of IDRC, and it's such a pleasure to share our findings and how we address gender and power issues within this project. We worked on effects of a mobile phone-based interactive voice response on common childhood illnesses in Ghana, and this was a quasi-experimental study. So within our study, the intervention that was developed was a mobile phone-based interactive voice response. And the intervention involved a mobile phone-based system which monitored childhood conditions, offered telemedicine consultations, and delivered child health promotion messages on nutrition and management of common childhood illnesses to caregivers. So in Ghana, when it comes to caregiving, it's mainly left with mothers, aunties, grandmothers, and often the men are seen to provide. So we went through a different channel. We started with the men. We decided to educate the men about the essence of this intervention and how it could impact child health within rural Ghana. And so starting with them was seen to be a very good approach. And then in that way, they were able to empower their women to tell them that if the child fell sick, pick up the mobile phone, dial this toll-free number. And they could mention the numbers because they felt a part of the project. It wasn't the usual thing where men were left to be in the house and women did all the answering of the questions regarding their child's health. Men were able to detect that their child had fever, and some men even called in when a child was sick and wouldn't bother to even call the mother. They went in straight away to access the system and made these complaints. They received messages. They were able to speak to a physician as men. And so this approach really helped us, and we saw a great difference. Within our data analysis, we made sure we disaggregated our data to show how many male caregivers called into the system and how many females called into the system. And this is one of the projects that has seen that males can really be involved in the health of their children. And this is because we involved them first. We really empowered men and made them know that they could be directly involved in the healthcare of their children and not just provision of money. And we also made sure that we received feedback from them as a form of monitoring. And this was a way that kept the project going and having the men involved from the beginning to the end of the project. I'm also happy to say that within this project, we were able to identify adolescent mothers, and we were able to champion for them to have focused antenatal care and focused postnatal care, and then to empower these young ladies to say that they have a future, for them to know that they can take care of these children by using some of these systems like the mobile health information systems so that it could help them with their children. So from Ghana, it is that male involvement really made a difference with our project. Thank you very much.
Thank you very much, Princess. That was very interesting. And you can really see the life course approach taken across the different projects in the Cedar cohort. We have neonatals, we have children's health, we have adolescent health. So lots of interesting topics being addressed, and gender and inclusion as central themes throughout all of the projects. Now, I just wanted to, before we move on to our final speaker in the second panel, I wanted to remind people to not be shy, and we do have a Q&A box. If you go to the top menu bar, it's right between people and chat. You see a Q&A. So if you want to pop in a question, we'd be happy to respond to it during the Q&A session that follows. So now I have the great pleasure to welcome Dr. Aisha Shalash. Dr. Shalash is based in the West Bank. She is a public health researcher at the Institute of Community and Public Health at Birzeit University in the West Bank, Palestine. And again, you can find her more complete bio in the chat. Dr. Aisha, I'm going to invite you to share with us a little bit about your experiences through your project.
Okay, thank you so much. Our project was on strengthening the adolescent sexual and reproductive health and rights health information system in the West Bank, and it tackled gender and power relationships across family, community, and system levels by identifying how deeply rooted gender norms limited adolescents, particularly young unmarried girls, from accessing and benefiting from health services. We assessed healthcare providers' gender awareness, uncovering their biases and highlighting the need for providers to better support adolescents' autonomy in their sexual and reproductive health right decisions. At the system level, we mapped adolescents' health indicators, showing that there was a lack of data for younger adolescents aged 10 to 14 and adolescents males. This led to the foundation for the prioritization for the collection of these indicators within the health information system, allowing more inclusive health policies and services. We included marginalized voices by engaging adolescents through focus groups and surveys. And this allowed adolescents, especially girls, on marginalized youth, such as the displaced populations, to discuss their concerns about their privacy and confidentiality and trust in healthcare settings. And so this participatory approach helped identify adolescents' fears, perceptions, and expectations whenever they visited healthcare providers. We actively participated and continue to participate in the Palestinian Adolescent Health Coalition, which brings together all of the different organizations in the country working on adolescence. And so this helped to make sure that our efforts were collaborative and different organizations were not repeating the same interventions to ensure that resources were used efficiently. And one of the main project accomplishments was the empowerment of young female researchers through mentorship. Our project supported 3 female master's students, 1 PhD student, and 1 postdoctoral researcher. And I was the PhD student that was given the opportunity through this project. And today, however, as you may all know, that we face even more challenges than ever before with the war on Gaza and our increased mobility restrictions across the West Bank. Already intensifies the already existing vulnerabilities, increasing health disparities, and further silencing marginalized groups. And so adolescent girls, young people, and displaced populations face so many challenges: limited mobility, disrupted healthcare access, higher risks of gender-based violence, and severe mental health strains. And these escalating crises show how critical it is to have high quality, inclusive, and gender sensitive health information, especially in humanitarian emergencies, which we're currently facing right now. So moving forward, our experiences need to highlight the need to protect and enhance our data systems capable of quickly identifying and addressing gender specific adolescent health needs. And so as our humanitarian situation increases, the need for accurate, timely, and inclusive data to inform the humanitarian response and safeguard our adolescents' rights grew even more urgent than before. And so ultimately, our collective work must continue to place adolescents' rights at the center of our crisis response in both our immediate humanitarian relief and our long-term system strengthening. And so this experience has shown us that the genuine change occurs when research is deeply rooted, grounded in the lived realities and voices of adolescents, especially now when they're navigating crisis and conflicts, as I bet you've all seen in the news here recently. And so thank you so much.
Thank you so much, Aisha, for that very thoughtful presentation. And context really does matter in all of the research and the work that everyone is doing. I am now going to pass the floor back to my co-moderator, Mary Gloriose. Please, Mary Gloriose, over to you.
Thank you very much, Cedar, and thank you all panelists. Really amazing intervention. I think we learned a lot. And for those who can, if you can just put in your clap, electronic clap, it would be great at least to acknowledge and thank our panelists. So thank you all. This is the time we mentioned in terms of your questions. We're not seeing much in the chat. Maybe to kickstart, we if you allow me, I have a couple of questions. The first one, and feel free to jump in as you see fit, would be as you really clearly described how you engaged with the local community policymakers in making sure that the design and the interventions of your project are really relevant. Wanted to know really what kind of challenges and successes you've really experienced in co-creating interventions with adolescents. Do you want to go ahead? But first, I know we were waiting for Irene to join. Unfortunately, I believe she wasn't able, given some technical issues, but if she's able to unmute herself, we'd love to hear from her as well. Irene, are you there? So sorry again. I mean, today has been a technological challenging day. So, but we'll be happy also to add maybe the chat, her presentation of what she wanted to share. So apologies for that. So yeah, to come back to that question, if anyone in the maybe panel one could respond, and as they're addressing that, maybe for the second panel, especially in even the first panel, as Via was mentioning, really to talk about or share with us some of the key challenges that you faced in translating the research findings in the policy or practice in the context of fragility. So who would like to start?
Could we ask that all the panelists maybe turn their camera on? Sorry, go ahead.
Yes.
Yeah.
Would like to go ahead, please.
Okay, so I'll start. With the challenges with the interventions that came from co-creation, I'll speak specifically on the one that the men were proposing that we allow them to sit in the adolescent health club to observe what education, sexual and reproductive health education, the health workers give to the adolescent. And when we tried that, one of the challenges was that typically the health workers were very careful in saying what they want to say, and the children were also not really at ease in us because their parents were there, their fathers were amongst them. So really, you typically how the adolescent health education goes during the club meetings, that really did not happen. So the way the children were free to ask questions, they were really not at ease in asking questions. So that intervention really was a bit challenging moving forward, because the men said they would come as soon as there's a club meeting, they will join, because they really want to monitor what is going on, because they feel like the health workers are giving bad ideas to the children, to become promiscuous, to have sex and all that. So that has been a big challenge for really the project. Another one is the health workers. So the health workers, as I said earlier on, they were very judgmental, morally judgmental, when these adolescents walk to the health facility to seek information on contraception and all that. And we educated them, but when we went back for evaluation and the end line, some of the adolescents still complain that when they go, the health workers, sometimes the way they look at them, some of the kind of response they give them discourages them to come to the health facility for information. So they'll rather go elsewhere to seek for the information than to come. So it's a big challenge, making the health workers be more professional and not morally judgmental. So that has been the challenge. But for the successes, what I would say is that when it comes to the communication between adolescent and their parent, when we train the mothers on the effective ways to communicate these sexual and reproductive health issues, because it's more of like a taboo for a child to go and ask the parents about sex organ, about other things. It's more of like a taboo in the district, the community. But when we train the mothers with the skills, when in the end line, there has been a positive result. So more of the mothers are now engaging their adolescent girls and boys in this conversation. So that has been a huge success. Over.
Oh, wonderful. Thank you so much, Dr. Desmond. So really great to understand indeed the importance of building trust with all key stakeholders, as well as really sensitizing the providers, the communities, those really often gatekeepers in the community. So maybe come quickly, the second question was asking, particularly in the fragile or resource constrained settings, any of the key challenges you would like to share in translating the research findings into policy or practice? Who would like to share your experience? Yes, go ahead, Dr. Kader, and then Dr. Rick.
Yeah, thank you so much. For JSANS, the project was implemented successfully. The data collected and the surveillance system and the quality system helped out actually to do significant changes in the health system and mainly in hospitals, and this is actually this evidence and impact is seen by the policymakers. After implementation of JSAN, they decided, oh, look, it is really a successful intervention. Now we need to integrate it with maternal mortality. So we need to integrate maternal mortality indicators in the whole system. I told them, listen, just keep JSANs, and then develop the system. At later stage, we will integrate them. But unfortunately, the decision makers decided, no, we need to suspend now the system and to integrate them together. So now we have a gap actually of a few months where we are not recording neonatal deaths and stillbirth. Now the Ministry of Health, the good thing is that they are now working to scale out the program, or the project or the system, but they need to integrate maternal mortality indicators and children under 5, mortality under 5. So we are looking for, so there is some delay from the decision makers, and hopefully we will see a united system running in the country. You're unmuted.
You're on mute, Mary Glorios.
Yeah, I knew this was going to happen. So apologies. I was saying thank you so much. And as this is really illustrating how important to engage all the stakeholders from the beginning, the design and everything, to be able indeed for them to own the results. And in your case, to really hear amazing impact in scaling the work of the project. There was also, I think, the intervention from Dr. Wick.
Yes. Yes, thank you, Marie Glorios. So as I said in the presentation, we identified, the Reproductive Health Working Group identified bringing together researchers in research workshops as one of the strategies to support researchers and to overcome their isolation. But of course, that's easier said than done. It's not easy to bring researchers together in a militarized research region like this one. It's hard to get visas, especially for certain nationalities. So there's these kind of bureaucratic issues involved that make it really challenging, actually, to bring researchers together from different national contexts. And then there's the second challenge about doing research in a crisis setting that has more to do with the kind of how do you do research kind of question, which is about being so close to, when you're a researcher and you're so close to the to the area in crisis. And so it's really difficult to do research in those settings. You need you need a certain distance in order to sit down and say, okay, this is what is going on. And it's not always easy to have that distance in a crisis setting, and especially for scholars who were displaced, for example. I mean, as they're moving their families and restarting their careers, it's really in a new place. It's really hard to do research and have that kind of analytic distance, you call it in the social sciences, kind of that distance of the researcher to his or her research field, research topic. So I would say those are the two main challenges for researchers working in a region characterized by crises and wars.
Wow, no, thank you so much. Thank you, really, indeed, that importance of being inclusive. At the same time, really need to be to acknowledge what the researchers in those contexts are going through and what may the potential impact. Absolutely. So I think we were running a bit. We were trying to see how we can stay in the time so that those, I know, Matt, you want to say something? I don't know if it's maybe 30 seconds. Can you please, so that we can try to wrap up?
Yeah, I just wanted to add that a major challenge that we faced was whether we should call it child marriage or early marriage in the Gambia. It was difficult for us to arrive at a definition, because who is considered to be a child at the community level is different from, if you look at the national policy that we have in place. So we were, trapped in between, not knowing whether to use child marriage or early marriage in the case of the Gambia.
Okay, wonderful. Thank you. That importance of concept and the word we use, indeed, in this case. So thank you so much, and thanks to those also who contributed in the chat, to Priscilla, Prempi, in terms of sharing also their experiences in doing this kind of work. So I want to now thank you all and give the floor to Chetali to close, and Montasso as well. Thanks.
Thank you so much, Mary Gloriose, for moderating this great question and answer session. We are trying to keep on time. We're at the end of it, so I'll be brief. You'll see that there's a slide up right now where we asked each of the panelists to just leave you with some takeaways, some parting words, which I thought would be nice because we didn't get to hear from all of them in this Q&A session. So thank you again for all the participants for joining this webinar. We hope the contributions from the authors working across West Africa and the Middle East on issues of adolescent sexual and reproductive health, as well as strengthening health information systems, provided some insights and food for thought from their respective contexts. Now, I will invite back Montaser Kamal, Director of the Global Health Division, to formally close this event.
Thank you very much, Chetali. Can you hear me?
Yes.
Great. Thank you very much for all our speakers and our audience who has sort of, in spite of the technological challenge, they came back to really take part in this very important and very interesting webinar. Thank you again, the speakers, the moderators, the journal team, and of course, to everyone else that has taken part in the meeting today. We believe in IDRC, we believe that knowledge is key to the future of where every community is self-sufficient, healthy, and prosperous. We invest in research that transforms lives and livelihoods in emerging economies, spurs innovation for healthy industry and trade, and builds trust and goodwill between Canada and the rest of the world. Ce supplément et le dialogue d'aujourd'hui s'inscrivent dans un mouvement plus large qui met l'accent sur le leadership communautaire, l'équité entre les genres et l'action fondée sur des données probantes. Nous vous encourageons à lire l'intégralité du supplément, à le diffuser largement et à rester engagé avec nous dans la poursuite de ce travail. Merci et excellente fin de journée. Merci, au revoir. Thank you very much, everyone, and have a great rest of the day. Bye.
Bye.